Since 2020, UVA Health has established programs to deliver care to both children and adults with COVID-19 locally in Virginia and throughout telemedicine programs in Southwest Virginia as well. Our clinicians also partner with healthcare providers in other parts of the Commonwealth to educate them on COVID and post-COVID care, including our interactive home monitoring approaches and caring for patients in isolation. Part of UVA's health mission is to advance medical research. We have scientists working to design the next generation of COVID vaccines to prevent COVID and long COVID altogether. Some are developing treatments to prevent the long haul of pulmonary complications and other potential therapies for their inevitable reality that will be treating patients with long COVID symptoms for years to come. Long COVID has become part of our new normal. The demand for a long COVID clinic is increasing each and every day, and patients are traveling from afar to really get their care. Today, we're especially grateful to the members of the Virginia delegation, Senator Tim Kaine, Representative Don Beyer, and the Senators Ed Markey, Tammy Duckworth, Representative Jack Bergman, Lisa Blunt Rochester, and Ayanna Presley, who have introduced legislation to address the gaps in research, care, and resources for patients with long COVID. I'm so grateful today for Senator Kaine and Congressman Beyer who are with us today. So we're going to start with Senator Kaine. I know that you joined us. He was elected to Senate in 2012 and serves on the Armed Services, Budget, Foreign Relations, Health, Education, and Labor Pensions committees. And we just welcome you. I know that you have a few comments to share with us today, and thanks for being here today.
Well, Wendy, I'm so happy to be with you. It's a busy day in the Senate, racing here to there, but I wanted to do this because you're doing the Lord's work. This is such an important topic, and we have so much more to do and so much farther to go. So let me thank you and everybody at UVA Health for holding this so we can learn about the latest in research on long COVID, but also hear from challenges being faced by long COVID patients. There's still so much to learn about it, and I know this from personal experience. I got COVID when we were passing the CARES Act in March of 2020, very early. I had a non-standard case of it. I didn't have any of the symptoms that at that time were thought to be kind of the major COVID symptoms. I didn't have fatigue. I didn't have respiratory challenges. I didn't have loss of taste or smell. But I woke up one day and I just suddenly got hit with a blizzard of allergic reactions. I had pink eye. I had skin rashes that would appear and disappear. And I had a very bizarre nerve tingling sensation 24/7 everywhere on my body. My case was mild, and as I say, I didn't think it was COVID until I went home, and then I immediately gave COVID to my wife, and she had a very standard case, just one more thing for a husband to feel guilty about. But thank goodness both of our cases were mild, and within a week, we were feeling great, except this nerve tingling thing, which switched on like a light switch, has never gone away. So 3 years later, I still feel like every nerve ending in my body has been dipped in an Alka-Seltzer. Not painful. I can work, I can focus, I can exercise. It's a little bit harder to sleep, but it definitely taught me long COVID is real. And once I chatted with my neurologist about it, I kept thinking it's going to go away. 6 months it hadn't gone away. I went to my neurologist and he explained to me that a lot of viruses have post-viral neurological or other consequences, and that's what I'm dealing with. I decided to talk about it because I was running into so many people, and in fact, I just was talking to somebody today who's having the same experience, who have long COVID symptoms, and they're not being believed. And they even feel stigmatized if they share that they have an energy deprivation, or they're worried about, can they stay at a job if they're experiencing heart palpitations or some of the other common symptoms of long COVID. So I've been talking about it pretty openly, and that has meant that many people who are dealing with long COVID issues come to my office and share their stories, and I'm glad they do. They need to know the folks dealing with long COVID need to know that there are people who are their policymakers who are sitting on key committees like the Health Committee, who not just hear them, but believe them, because we are going through it too. And I'm not the only person in the Senate or in Congress who's dealing with long COVID. I may be one of the only ones who's kind of just been upfront about it, but I'm definitely not the only one dealing with it. I have a couple of bills that I'm excited to work on, particularly with my friend Don Beyer of Virginia, who is the House lead of the Care for Long COVID Act. We are doing everything we can every year in appropriations bills to make sure we're putting dollars in, whether it's to communicate with providers, employers, and everyday folks just like me who are dealing with long COVID. We need more research, and the good news is there are some promising stories. Even as we are still murky about causes, we are finding that there are some treatments that work. Maybe the treatment was developed for another physical condition that has a similar symptom, but when applied to the symptoms of a long COVID sufferer, those treatments can have some efficacy as well. So we are finding some treatments that are working. One interesting one that I have found is I've now interacted with a few people who what long COVID did is it caused an underlying health condition that had never been diagnosed to sort of ignite and surface. And so the long COVID symptoms are actually related to other conditions that they had previously not known about, but you can treat that condition itself. And so people are finding some relief that way. But I'm just really excited that UVA Health is devoted to this. A long COVID clinic, you're treating people from the UVA hospital system, for those who aren't personally familiar with it, has a huge geographic area that it serves, a huge geographic area with clinical outposts and outreach all over Virginia and beyond. So you're helping a lot of people, and we need to do more up here to help a lot of people. And with that, Wendy, I just wish you the very best in your work and the very best in this webinar today.
Well, thank you. And thank you for your openness, and thank you for your advocacy and for being here today. We're truly grateful. So thank you for your time. Really appreciate it. Next, Congressman Don Beyer from Virginia, 8th District, representing Arlington, Alexandria, Falls Church, and parts of Fairfax County, such a big area. He serves on Congress's Joint Economic Committee and the House Committee on Ways and Means. Welcome. So glad you're here today.
Thanks, Wendy, very much. And thank you to UVA Health for holding the seminar, for inviting me to be a small part of it. And it's always a pleasure to follow my dear friend, Senator Tim Kaine. And nobody speaks with more authority on this topic than Tim. And what we're talking about is really important. We've all experienced a traumatic event in our lives, the pandemic, and it's radically changed how we operate our lives in so many, many different ways. But while many in America are returning to a pre-pandemic posture, I saw that this morning driving to work, where getting across the 14th Street Bridge was a 15-minute effort. COVID hadn't disappeared yet. And that means that what we're looking at now, as I understand it, is a virus circulating with a risk of 6 to 7% of the population are going to get the long-term symptoms. And we still have folks that were previously infected like Tim, that we haven't been able to relieve their symptoms. I know that millions of Americans acquired long COVID. I've seen numbers between 7 and 20 million Americans that had long COVID at one time or another. And the economics are 2 to 3 million Americans are out of work right now because of long COVID. Mm-hmm. If you look at labor force participation, one of the great drivers of economic growth, lose to 2 or 3 million Americans out of the workforce is a devastating impact on our economy. And this is a disease that continues to evolve. We're still trying to figure it out. We were thrilled that when vaccines came out, and even Paxlovid, that it did help some cure the long COVID symptoms. I was really hopeful that it would do that for Senator Kaine, but clearly they're not the cure for all. We know that women tend to get hit a lot harder with long COVID. We know that some people are permanently disabled. I had a conversation 2 nights ago with a friend and father whose daughter in her early 40s has been in bed for 3 years now with long COVID. And not just the fatigue and the exhaustion, but hallucinations, inability to handle sounds or motion or even smell. Really dangerous stuff and different person to person to person. So as Tim Kaine said, there's a lot more we need to do in Congress. Senator Kaine and I have this bill together he mentioned, the Care for Long COVID Act. It is bipartisan. Republican Jack Bergman, who's a 3-star Marine general from the Upper Peninsula of Michigan, is our partner in the U.S. House. And we're trying to connect the dots on what treatments work for whom, to educate providers to know what to look for and how to care for long COVID patients. And also for those that are disabled right now, hopefully not permanently disabled, to connect them with the disability services that they desperately need. I'm also partnering with Ayanna Pressley, who's a member of Congress from Boston, on her bill, the Treat Long COVID Act, which is specifically to fund a lot more long COVID clinics, especially in underserved areas, and support the providers that are focusing on long COVID. So with Tim Kaine, with Ayanna, with Jack Bergman, with many others, we will continue to do our damnedest to get the money to NIH and to the long COVID providers. There's a lot more to do. I'm so pleased that the UVA has put together this panel to talk about the latest research and where we go from there. So Wendy, thank you so much. And I yield back.
Well, perfect. And thank you both so much for all your work in advocating for patients affected with long COVID. We're so grateful for your time today. Thank you so much. So now I'd like to turn it over and introduce a couple of presenters that are going to talk about the current state of long COVID research and their federal agency roles in long COVID care. So first, Dr. Clinton Wright. Dr. Wright is a vascular neurologist and a specialist in cognitive disorders. He's an associate director of the National Institute of Neurological Disorders and Stroke, the NNIDS, and the director of the Division of Clinical Research and a member of the stroke branch within the Division of Intramural Research. Welcome, Dr. Wright. Glad you're here with us today. Thank you.
Thank you very much. It's a pleasure to be here to share what we're doing at NIH about long COVID. Wonderful. Yes. So as Senator Kaine and Representative Beyer said, long COVID is real. There are a lot of people that are suffering, and the Recover Initiative, which is what I'm going to tell you about, was designed really to get to the basics and really understand it. Next slide, please. So as you can see from this slide, there are many, many symptoms, many different organ systems involved, and that required a very multidisciplinary approach, most importantly, to understand a set of conditions that really were not understood, that really needed to be characterized for the first time. Next slide. So the Recover Initiative was really designed to understand a new set of conditions, to be able to predict them, to treat them, and to prevent long COVID and the post-acute sequelae of COVID. The key aims are listed here, but they are pretty straightforward. Understanding the epidemiology, who gets it, what does it look like when people get it, what are the underlying biological mechanisms that are causing it to happen, and how can we treat it? And one of the things that was so central to Recover was the patient voice, because as was so eloquently stated by Senator Kaine, there are a lot of people suffering from many different conditions and symptoms, some of whom really were not being listened to. And so we really wanted to listen to them. Next slide. And so the patient and the participant has been central to Recover on all different levels. So Recover needed to be at national scale, but we really wanted it to be patient-centered. And so patients and participants were involved in really telling Recover what were the symptoms that mattered to them. And then they have been included in all different levels of the program, the steering committees, the highest, executive committee, the different scientific working groups that are looking at different facets of the condition, as well as the oversight committees. Next slide. And, I think Senator Kaine said, long COVID is real, and that's absolutely true. And there are other post-viral conditions that people have suffered from, like myalgic encephalitis, chronic fatigue syndrome, and others that have symptom clusters that overlap with some of the folks that have long COVID. And so really understanding those links and being able to capitalize on the prior experience of those patients to inform how Recover was designed has been critical. So we had a national community advisory group that included about 50% of them were patients, and they really helped not only to add to the functional assessments and modify the surveys that were being asked, but also to expand the inclusion criteria. And one of the major things was to allow people in that didn't have a PCR confirmed test, but had the appropriate symptoms and the timing that made sense for someone with a long COVID. On the left-hand side, you can see the many thousands of patients that have been involved in different aspects of the patient engagement component of Recover. Next slide. One of the other things that was really important was to make sure that Recover represented everybody in the United States that has long COVID. It's one thing to be patient-centered, but it's also another thing to really engage the community and partner with those groups and identify people and allow them into the study. And so you can see in the little table on the right-hand side, the percent of the US population, for example, made up by some different racial and ethnic groups. Then you can see the percentage of US COVID cases that were made up by those groups. And then you can see the percentage of our cohorts in Recover that are made up by those groups. And you can see that Recover was designed to be enriched for folks that might have been underrepresented in research in the past, but are very well represented in those affected by long COVID. Next slide. This slide shows you the overall structure of Recover, and you can see that there are a number of cores, such as Patient Engagement Core, the Clinical Trial Data and Coordinating Center, the Clinical Science Core, the Data Resource Core, and the Biorepository Core. And those cores support a number of different endeavors. On the right-hand side is the tissue pathology studies, then the pathobiology studies to really understand the mechanistic underlying disease pathogenesis, the electronic health record system studies that include 60 million records and more than 4 million COVID cases, and then some longitudinal cohort studies that I'll talk about in a minute, and then the clinical trials. And then out of those different studies come data resources that will then be applicable to the scientific community to be able to analyze and examine, including everything from clinical data to imaging data to mobile data, real world data, and pathology. Next slide. One of the key components of Recover is the observational cohorts, and they are three basic groups. One is the electronic health record data that I just mentioned, and that includes patients across the lifespan and leverages both adults, children, pregnant individuals. The other is the clinical meta cohorts, where almost 30,000 people have been enrolled so far, that include people that either had acute COVID and were then followed to see if they developed long COVID, or people that already had long COVID, or controls that did not have it, to really try to understand and phenotype the disorders. And then the longitudinal community-based cohorts, which are long-standing cohorts that have been going on for many years, that then asked questions and did phenotyping and were able to follow people that developed long COVID within those cohorts. That gives a tremendous opportunity. Next slide. And so the real world data and electronic health record data has helped us understand the different symptoms. And you could see on the left-hand side that in adults, it identified almost 140 long COVID-related diagnoses with 44 clinical features and 21 syndromic clusters, and helped identify some of the dominant phenotypes in adults. It also showed some of the risk factors, such as comorbidities and different demographic groups. And then on the pediatric side, 121 symptom features, as well as dominant subphenotypes in children and risk factors in children, such as younger age or being admitted to an ICU or having complex chronic conditions. Next slide. And the adult cohort has been going on, and as I said, almost 30,000 people enrolled across the different cohorts. The primary analysis paper from an interim analysis is going to be coming out in the next couple of weeks. Some of the notable findings include the identification of 33 symptoms that were significantly more likely to be present in infected compared to uninfected people 6 months after the initial infection. as well as a symptom-based research tool with criteria for identifying patients with long COVID and PASC, as well as the identification of distinct PASC subphenotypes, and then the importance of viral variants, including the virulence of the variant, the effect of variants on the clinical spectrum and its severity, the protective effect of vaccination, and the potentiating effects of multiple reinfections. Next slide. And then finally, the clinical trials. There are 5 master protocols to run platform trials in long COVID. The first addresses the lowest hanging fruit in terms of the underlying pathophysiology or pathobiology that we think may be involved, such as the persistence of the virus beyond the acute infection or dysregulation of the immune system, which sets people up for long COVID. And then the other 4 include the different symptom clusters that are most affecting patients, and will target those with different therapeutic strategies, such as brain fog, autonomic dysfunction, sleep disorders, and exercise intolerance and fatigue. And all of these master protocols will allow multiple therapeutics and therapeutic strategies to be tried, but they will have shared endpoints and regulatory frameworks and common data elements. They will have a shared approach to patient inclusion, and they will have the ability to rapidly assess target therapeutics and enable cross-trial analysis, which will be critical in untangling this scourge of long COVID. Next slide. So thank you very much, and I will hand the baton over to the next speaker.
Well, thank you. And thank you for sharing Recover and all that is taking place. We wanted to also introduce AHRQ presentation. Next is Dr. Robert Odo Valdez. Dr. Valdez was appointed Director of the Agency for Healthcare Research and Quality, AHRQ, in February 2022. He was previously the Robert Wood Johnson Foundation Professor Emeritus of Family and Community Medicine and Economics at the University of New Mexico. Wanted to welcome Dr. Valdez. Thanks for being here.
Thank you very much. And thank you, Representative Beyer and Senator Kaine, and of course, our host, UVA Health, who've done some tremendous work in the state of Virginia. Next slide, please. The next slide, please. For those of you who are not familiar with the Agency for Healthcare Research and Quality, the agency has a unique federal role to play within the Department of Health and Human Services. Alongside our other 3 science-based healthcare agencies, you just heard from NIH, who does all of the research from bench to the early identification of potential cures and treatments, to our sister agency, FDA, who makes sure that all those discoveries are safe. It falls to AHRQ to really begin to generate the scientific evidence and disseminate and help implement actionable knowledge in our healthcare delivery system, so that making 21st century is a reality for everyone. I like to try to explain AHRQ because most people are more familiar with our larger public health system, sister agency, the Centers for Disease Control. AHRQ is to healthcare systems as CDC is to public health systems. And by that, I mean, we work with and do our work through partnerships with the private sector and with patients and consumers who are consuming healthcare in our country. Next slide, please. Thanks to Senator Kaine and his staff and their support, AHRQ was able to hold a Virginia summit of healthcare providers throughout the state and to meet with patients throughout the state to better understand what was going on in the care delivery system, to understand the needs of clinicians and healthcare systems. The most important part of that summit really was hearing personal stories from patients. A woman who had to make 30 trips to the emergency department only to be told she was suffering from anxiety and a disbelief that long COVID actually existed. an 11-year-old boy who told us that he was told he couldn't have long COVID because he wasn't coughing, or the nurse whose COVID led to severe chest pains, which she was told was a mere panic attack. And so many people have experienced long COVID for such a long period of time. My neighbor in New Mexico experienced long COVID early, like Senator Kaine did. He lost his sense of smell. He was a coffee lover, and to this day, he still hasn't been able to enjoy a cup of coffee. Now, he's had some mild situations, but others in our community have experienced the kinds of symptoms that have left them unable to work, unable to engage with their children or their grandchildren. And in fact, many of them have lost hope. And when people lose hope, they're ripe for the snake oil salesmen. And really, they've also expressed an increasing loss of trust in our healthcare delivery systems. So it was really great to have patients tell us in Virginia that they finally had hope. They'd found a clinician who believed them that long COVID was affecting them, who listened to them and was able to bring them some really guidance about what they needed to do to relieve their symptoms so that they could engage in their life again. Clinicians and health systems told us of the issues that lead to one of the things that's best known about U.S. healthcare. We're a highly fragmented delivery care system. And so when patients brought records from one system or one set of providers to another, they were not available to clinicians. There was the need for up-to-date long COVID care information. What was the best that we had to offer today while we wait for our colleagues at NIH to do the science that's necessary to bring those discoveries to the forefront? We needed practice guidelines and a desire by the practice community to develop a learning community. The fact that many patients are dealing with brain fog and extreme fatigue and severe headaches today requires us to act today and to assist our healthcare systems and clinicians provide the care that can provide at least some relief to the symptoms that people are experiencing. Next slide, please. So in order to assist our colleagues who are on the front lines trying to serve patients with care, we are engaged in our effort to try to identify care models and best practices to, first of all, reduce fragmentation in our system so that primary care providers can engage with specialists. As you heard from my colleague before, it really is a multi-system set of issues and a constellation of different kinds of symptoms that people are experiencing. It's really about how we treat people with multiple chronic conditions or multiple symptoms. It's a recognition that long COVID is a good example of a post-viral infection that creates a variety of other experiences that we know something about, and that we also need to do a better job of organizing and delivering services for people who experience post-viral infections. And the largest number, of course, are the patients who are experiencing long COVID. One of the biggest messages that came out of our work so far is really our need to enhance the patient experience so that patients can regain the trust that they have in our healthcare system and in the science that we are able to provide that creates a 21st century care delivery system. We're continuing our work across the country to try to provide support for the development of long COVID clinics in smaller communities and to enable primary care practices to use emerging knowledge. Just as my colleague was saying before, they're beginning to get a handle on some of the underlying relationships and some of the treatments that are potentially useful, but also in practice in the way in which medicine has advanced historically. there's much to be learned by the practice community sharing best practices. So I want to thank you for your attention and for hearing out what we're doing. And I particularly want to thank the patients who've been willing to share their experiences so that we can create a better healthcare system.
Well, thank you. And thank you both, Doctors Wright and Valdez. We really appreciate you sharing all the work of your agencies and all that you've done to drive research on long COVID moving forward. Just really want to say thank you to you both. And next, we want to hear from a patient, a patient story. Would like to introduce you to Maddie Smith, who's going to share her personal story as someone who has been diagnosed with long COVID. Maddie Smith lives in Tazewell County, Virginia. She's a nurse and a clinical administrator at the Program of All-Inclusive Care for the Elderly in Mount Rogers area, working with seniors and people with disability. Maddie has 3 sons, and she developed long COVID in late 2020. And her symptoms are slowly improving. Maddie, want to welcome you and thanks for sharing your story.
Great. Thank you again for having me. I'm really excited to be able to share my personal story with you all. As she mentioned, I'm in healthcare. So being on the other side, actually being the patient has certainly given me a different perspective. As she mentioned, I'm from a small town in Southwest Virginia. I'm a mom to 3 boys. I'm in healthcare and I work full time. On a Tuesday in September of 2020, I developed chest pain and shortness of breath, not typical symptoms for me. I went to the doctor, I sought treatment, and I was diagnosed with what they thought was a heart condition. Symptoms continued to worsen. So by Friday, I returned to my PCP. After some cardiac testing, it was discovered I did not have a heart condition. My PCP was convinced I was having anxiety and panic attacks. But finally, by that evening, I was actually diagnosed with COVID. I was pretty sick during active infection, but I was never hospitalized. I quarantined, of course. When quarantine ended, I went back to work. But as time passed, the symptoms like chest pain, fatigue, shortness of breath, brain fog, those symptoms that I had during COVID, they just continued to not get any better. And all of those were very atypical for me prior to COVID. Those weeks turned into months. So I started to feel like maybe something wasn't quite right, that I should be feeling better, and I wasn't. At first, I thought the lingering effects, would continue to improve. But as time went on, of course, I started to lose hope and get frustrated and feel very depressed that I just wasn't feeling well, feeling back to my normal. I sought treatment, but for several months was given no diagnosis and no answers. About 9 months post-COVID, I actually even went to the emergency room because I was having such severe shortness of breath and chest pain that I was concerned. So I sought treatment in the emergency room. I was actually fearful that I had like a PE, a pulmonary embolism. So I went to the ER and I was not taken seriously at all. I was basically treated as if I were drug seeking and ended up signing out AMA because I wasn't treated. And so, of course, I went home very frustrated. I had a lot of anxiety and just started to lose hope about, my prognosis and what was going on, because at that time I didn't have a diagnosis. I ended up following up with my PCP, continuing to follow up with my PCP. And finally, after several months, was officially diagnosed as a COVID long hauler due to the persistence of my symptoms. So this is after ER visits and lots of hospital bills with no answers. So I know that I'm not the only patient that's experienced that financial frustration as well. My PCP did blood work that confirmed that I had some abnormal values for a thyroid disorder. She actually sent me to an endocrinologist, and that endocrinologist was actually 3 hours away from my home. That was the first appointment that they could find for me. Because I live in Southwest Virginia, there weren't a lot of close options, but the closest appointment they could get for me with an endocrinologist was 3 hours away. And I was happy to go, but I had to wait several months to get in with the endocrinologist. Finally, when I did, I was diagnosed with Hashimoto's. an autoimmune thyroid disease. And I have to say that he was the first person that really took me seriously and was actually able to help me. He got me started on thyroid medication. He actually explained that I probably had this dormant and underlying. And then when I had the active COVID infection, that it kind of woke everything up and it made all of my symptoms much worse. So once I started getting treatment for the thyroid disorder, I started to see a lot of those symptoms start to improve and get better. Prior to finding the endocrinologist, I started really to lose hope. I started to get very frustrated. I had no energy. I had a lot of fatigue. I felt like I couldn't work the way that I wanted to. I have 3 sons. I was trying to coach soccer and t-ball and all of those things, and literally just felt like I didn't have the energy to get up and to move. So finding that endocrinologist was super helpful. But again, another barrier is that lack of specialists. People have to travel very far and wait a long time for appointments. And I had the means to do that, thankfully, but there are a lot of people in my area that don't have the gas money or the time off to make these long trips to seek specialist appointments. So that lack of care availability is certainly a barrier for a lot of folks. Not only is the stigma of long COVID a huge barrier to patient care, that lack of access to care is important. That lack of specialists in small rural towns is a common occurrence and something that really limits a lot of people from being able to seek the care that they need. Also, a lot of providers don't truly understand the effects of COVID. As Dr. Valdez mentioned, that lack of learning community would have been, that's a huge issue. That learning community being in place would have been very helpful for my PCP in getting me answers more quickly than I was able to get answers and treatment. I was grateful to find a provider who knew what was going on and took me seriously, but a lot of people aren't in that same position. I'm thrilled that I was able to get a diagnosis and get treatment so that I could start having symptom improvement. So I'm both blessed and lucky because a lot of long haulers haven't been able to find the right answers for their recovery yet. And I think a lot of that is due in part because they haven't found the right person to really take them seriously and point them in the right direction. So this is very meaningful work. I'm really thrilled to be a part of it and to see that so many people are really acknowledging the severity of long COVID and the effect that it has on our communities, not just the physical health, but from the aspect of the mental health piece as well.
Maddie, we just want to say thank you to you for sharing your story. It's really important, and we wish you continue healing and really providing hope to others as well. So thanks so much for being with us today. Now, I'd like to turn to our panel discussion with 2 physicians, Dr. Kyle Infield and Ina Stevens, who are going to share a little bit more about our program here at UVA. So first, I'd like to introduce Dr. Kyle Infield. He's an associate professor of medicine in the Division of Pulmonary and Critical Care here at UVA and serves as the associate chief medical officer for critical care at UVA Health. He currently serves as the associate chief medical officer for critical care. He helped develop our special pathogens units to care for patients with Ebola in 2014, which helped us prepare UVA for its COVID response and for COVID-19. Kyle, I'll turn it over to you. Maybe just quickly, I'll also introduce Ina Stevens. Ina is a professor of pediatrics and pediatric infectious disease and integrative health at the University of Virginia here at UVA. Ina is a pediatric infectious disease consultant for UVA Children's Hospital and has a particular interest in children with special needs and mental complexities. She's also a doctor of medical yoga and integrative health at UVA Medical Center and the School of Medicine. So welcome to you both. The first question for you, Kyle, Can you talk about the current clinical care experience for patients that we have with COVID? How many patients are you caring for at the long COVID clinic here at UVA? What's the current demands? What does it look like? And what has changed from the earlier part in COVID until now?
Thanks. I think Maddie Smith really described a lot of the experience of long COVID for the patients that we see at UVA as well. There's a broad spectrum of patients that come to our long COVID clinic, which was started in March of 2020 by one of my colleagues, Dr. Alexander Cottle, and one of our fellows who really recognized that patients that were recovering from COVID at that point in time, which was predominantly patients that were in the ICU, were going to need ongoing care. Over the years, we have began seeing patients from the community as well who never were in the hospital. And the current demand for our services is significant. We are fortunate that we are able to work in sort of a consultative model and help patients and their primary care doctors continue care so that we can see more initial visits. But that demand is definitely there, and very appreciative of all the work that Congress, AHRQ, and NIH is doing to improve that.
Absolutely. And every day we need, more services and trying to get the care for patients. And you guys have done an excellent job. So thank you. So Ina, a quick question for you. What are the top barriers you and other clinicians are facing in working to provide healthcare to patients with long COVID?
Okay, thank you so much, Wendy, and thank you all for putting this panel together. I think it's really important. And I want to just thank Maddie very much for her, discussion of what she's been through. And she mentioned a number of these barriers already. And so I'm going to point out, I think, two specific barriers, particularly for children. As we all know, children get long COVID from all ages, and they present actually a little bit differently from adults. So I just want to start out a little bit with the difference between children and adults. Children are biologically different. They are neurologically, developmentally different, and they're going through different developmental milestones that adults don't go through. And so even a child who develops long COVID at the age of 5 is very different from a preteen, an 11-year-old who's very different from maybe a 16 to 17-year-old. And socially and emotionally and neurologically and developmentally, long COVID can have a tremendous impact on children, and it needs to be addressed. I will just start by, saying the impact of missing out on school. I know adults are missing out on work and they're missing their friends. Children are missing out on school. They're missing on developmental socialization of getting together in groups. And that's huge for children. So I think that one of the barriers is getting the children back into school, having the schools being on board with psychologists and counselors and teachers that are able to really help integrate them back into the school appropriately, and working with the medical community. So I do see just a little bit of a barrier there, a little bit different for children from adults.
Well, thanks.
Yeah, and then I kind of wanted to mention another very important barrier that Maddie brought up, and that is the fact that these patients are coming from all over the state, very, very rural communities where they may just have one primary care provider and, or a family practitioner for the entire town. They don't have the resources, and they may not see a lot of these patients, so they're not able to recognize the syndromes. So, and I'm not saying they're not educated. I think all physicians are working and very educated, but they may not have seen these types of patients. They don't know the resources that are out there, and they don't know maybe how to get the care and where to refer. So I think education is huge, and really getting the experts from centers from excellence, both pediatric and adult, to get that knowledge out to the rural community providers. And we have a model in pediatrics called VMAP, which is the Virginia Mental Health Access Program, which allows physicians and pediatricians from all over the state to access by phone call some mental health providers and get some real, on-time diagnoses and treatment plans and resources potentially for that patient. And I think this a model like this for patients and for providers out there in the community for patients that could be presenting with long COVID is going to be very important. How to recognize the syndrome, how to, evaluate the patients, how to refer them, what kind of resources they may need and what kind of therapies they may need. So I think that can be a help to some of these barriers.
Well, thank you. And talking about long COVID in children is something that we need so much more of. So thank you so much. Kyle, we just heard from leaders in the NIH and AHRQ about the state of long COVID research at their agencies and their work. What are their research questions, either biomedical, need to be answered to provide the best care that we possibly can for patients with long COVID?
Yeah, I'm very excited about the Recover program. And I think we saw during the height of the pandemic, the power of the platform trials and really being able to rapidly determine specific treatments that will help, because what our patients want right now is a therapy that we know is working. And because so many people are sick and many of them very disabled, they are seeking hope. And so I'm glad that the NIH is pursuing that line of research. I'm also really excited to see that they're including the importance of physical therapy and the recovery of these patients, addressing the ME and chronic fatigue syndrome symptoms with physical therapy has been problematic because of past research. And so I'm glad to see that that's going to be part of the ARM, because that's what our patients are going to need as they recover from the other symptoms and get back to their lives. We're going to need to know what is the best way of doing that. What I would also like to see is really an implementation science approach of how we take the knowledge that's produced by the NIH through the recovery platform and spread it to clinicians around the country. With the number of patients that we expect to have long COVID clinics, which may be an important resource now, can't be our long-term solution. And we need to make sure that our primary care doctors have the evidence-based medicine to provide great practice so that they can treat their patients with things that we know help them. So those would be the research questions that I would really like to see us aim for in the next coming years.
Absolutely, so important. And the resources that are needed are incredibly important as well. I know that you guys just asked for another therapist because therapies are so important in the COVID clinic for sure. So I know we heard from Maddie about her challenges as a patient getting treatment for long COVID. What resources or policies would help you as a clinician better care for patients with long COVID?
Okay, well, I think Kyle actually answered quite a bit of that, and that is really important in terms of making sure that, all the research that's coming down, all the new medications, what's going on with Recover is really, we have access to that, not only, at the Centers for Excellence and here at the long COVID clinics, but also for the physicians outside. But I think one thing that could be very helpful and a resource here is at any Center for Excellence in a long COVID clinic is having a multidisciplinary clinic. Maddie had mentioned, she was referred here and then she was referred there. And I know that my patients, if they need to see a developmental pediatrician, get the physical therapy, maybe see, behavior health and neurology, the referral list could be, 5 months for this patient or 2 months for this or a provider. And the care tends to be a little bit fragmented. And so it would be best if we had coordination of care with a multidisciplinary clinic, which takes a lot of time, it takes a lot of support, it takes a lot of administrative support, it takes a lot of space. But if I could put my, on a resource that would be really, really helpful, I think it would be a multidisciplinary clinic and have the patient kind of get evaluated by all the needed providers at the same time, so really can have coordinated care from going onward.
Yeah. And maybe a question for you both. During the pandemic, COVID was really, really tough, but there's been some bright spots. And we've heard throughout our discussion today that caring for patients with long COVID has been really, really challenging. But I'm wondering if there are any successes that you can point to, things that you're really proud of, any ways that care has been improved for long COVID patients so far.
I'm happy to talk about a couple of cases, and I'll take one from the early part of the pandemic where the majority of our patients were hospitalized in the ICU. We had a young gentleman who ended up having one of the longest periods of time on ECMO at our institution ever. He went out of the hospital on oxygen, really very dependent on his family for all of his care. And over the course of the next several months, when we would see him in our long COVID clinic and really the excellent work of our physical therapy team and others, we were able to get him back to being fully functional and back to work. That really was a team effort of pharmacists and physical therapists working together. And it's helped inspire some of the research that we've now taken on with centers like the University of Colorado and Johns Hopkins to understand how ECMO influences patients' outcomes. And the other was a young lady who got COVID at Christmas, who had previously been a marathon runner. She had been to, much like Maddie, she'd been to a lot of people, hadn't gotten many answers, came to UVA. We were really challenged to figure out what we could do for her. It was clear that there was a lot going on for her. We started with physical therapy like we do with many patients, trying to work on energy conservation and other techniques that help patients that have some of the chronic fatigue syndromes, but also through additional testing, diagnosed some cardiac problems for her that we've been able to treat. And while she's not sort of back to 100%, she's definitely improving. And I think being able to put a name on what's wrong with her has really helped her mental health as well, because no longer is she being labeled as someone who just doesn't want to get out of bed, but really knows what's going on and has some techniques of how to manage those symptoms.
Perfect.
I'm not going to necessarily talk about another patient, and I think success stories are huge, and I have similar patients, but I just want to mention one really important aspect that I think happened during this pandemic that improved care, and this was the access to telemedicine and having it be so much more accessible for patients out there. I have a patient that came into our ICU, very similar, was basically obtunded and with severe amplified musculoskeletal pain syndrome that we see a lot in children, secondary to long COVID, and she lived about almost 2 hours away. And for her to come back and forth into clinic was really very difficult for the family. And so I've been able to follow this patient for over 2 years, frequently with telemedicine, and seeing her when she needs to be seen, but also being able to work with her primary care physician. And this kind of coordinated care with telemedicine wasn't really happening before the pandemic. So I think that this is one kind of bright spot, that we've had some improved care, we've had some outreach, and we've been able to really reach patients and take care of them that way. So that's been very good. And having
awesome.
a webinar like this with everybody's support, I think is a huge thing for improved care. So thank you.
No, absolutely. And the power of everyone on this call. So, there are many people here today, and I think all of us want to see long COVID improve. And so would invite all the panelists, everyone that's contributed today, to think about one recommendation on how our guests listening today might be able to help us as we care for patients with long COVID. So maybe Kyle, you could kick us off.
Oh, kicking off with one recommendation is probably difficult. I would say that my one recommendation is really what we're starting here today, and what AHRQ and NIH and Senator Kaine have done, which is the advocacy for making sure that people understand that long COVID is an umbrella term that covers a lot of complications from a disease that impacted us all, and that we will have years of trying to treat patients with this condition, as well as the recognition that I think was brought up that currently we don't have that pill, the silver bullet with the vaccine or otherwise to treat long COVID. And we need to take the patients and their families seriously and help them as they move forward.
I would say the same thing for pediatrics in terms of one of the most important things to take away is the advocacy piece. I think children know parents know their children. They know when they're not doing well, and when sometimes you need to be a little bit persistent. And if they're being taken to an urgent care center or maybe to somebody that is not able to recognize what's going on, a quick visit, if they feel that their child is not doing well and their symptoms are not being addressed, to keep pursuing. And I think that there's hope out there, and knowledge is getting out there, and we can help make them feel better.
That's wonderful. And Robert or Clint, any recommendations from your perspective?
Well, we're working hard to try to do what we did in Virginia and other parts of the country, and that is to build that kind of learning community that so many of our colleagues need and want. Advances in medical care have often started there. Our understanding of biological mechanisms has outstripped our ability to actually implement them into actionable knowledge. But hopefully we've found a way to enhance our dissemination and implementation efforts that will assist Dr. Enfield and Dr. Stevens do their work better and to serve their patients more responsibly.
Yeah, and I would just add that the Recover initiative is going to take us quite far, but not far enough. We really don't know how long COVID is. How long is it? And what is the natural history of these diseases and these conditions? So that's extremely important. And in addition to that, we want to be able to do more treatment trials. The initial slate of trials that we are going to try, we hope that they will be successful, but we're also sort of building the plane as we are flying it. We're learning about this set of conditions as we go along. And so as we learn, we need to be able to adapt and come up with new treatments and study those new treatments. So we need the ability to do that. And that's where the efforts of Senator Kaine and Representative Beyer are so important, but also of everyone here. Thank you.
That's wonderful. And I just want to say again, thank you to everyone. Unfortunately, that's all the time that we're going to have for today. Just want to say thank you for your time and insights. And thank you to the audience for joining us this afternoon. After the webinar ends, you're going to be redirected to a survey. Please help us complete the survey and let us know your thoughts about the event. And we really appreciate your feedback. Links to the recording and additional information about this topic are going to be sent out to the attendees after the registrants and after the event. Continue the conversation with us, following UVA Health on LinkedIn, at UVA Health on Twitter, at UVA Health News. You can also watch a recording of this event on our YouTube channel at UVA Health. Just want to say thank you, appreciate it, and thanks everyone.